Hello, I'm Dr. David Pauly from the University of Minnesota. I'd like to share with you a literature review on clinical improvement after SI joint fusion. My disclosures, several of which are relevant to this presentation. A PubMed search shows that Sacroiliac has more than 7,000 results, SI fusion about 500, and SI fusion in clinical trials about 33. Here's a screenshot from the Sacroiliac search showing that there has been an exponential increase in publications on this topic. For sacroiliac fusion, we see a similar increase in publication rate dating probably to the 2000 time window. For sacroiliac fusion in clinical trials, we see the first publication about 2000, and over the last 5 to 10 years, significant increase in the publication rate. The best summary article was just published online in the International Journal of Spine Surgery. This was done by Lorio, Koob, and Aragi. It has 235 references and excellent summary tables and plots. The graphics I will be showing in large part in this presentation come from this article. The graphics show the pre-op status as being in blue, the post-op status as being in green. And when we zoom in, we see that the different devices have different markers or shapes on the graphics. And then the top part is lateral approach, and then the bottom part of the graph is a posterior approach. When we look at the visual analog scale pre-post, probably a 1/3 change, or about 3 points typically, is considered a clinically important difference. We see that several of the studies have significant overlap, so they may or may not achieve an MCID, whereas the aggregate data for the lateral approach shows clear separation and suggests that MCID is reliably achieved, whereas the posterior approach, the confidence interval does overlap significantly. For the Oswestry Disability Index, 12 points is a well-accepted criteria for a minimum clinically important difference. Here we see that the summary aggregate data for the lateral approach clearly achieves that 12-point change. For the posterior approach, it may achieve that. And again, where the bars overlap, there may or may not be an MCI difference between the studies. So if we look at the change scores in ODI, we see for the lateral approach, it does exceed the 12-point change, suggesting that it is convincing that the lateral approach achieves an MCID, whereas for the posterior approach, it is about at that 12-point change, and we see the Fuchs study clearly exceeds it, and the Ender study does not. VAS, similar picture, a 5-point summary aggregate VAS change, and for the posterior approach, probably about a 3-point change. There are 2 level 1 randomized controlled trial studies. Both of these utilize the iFuse device. The patients could cross over at 6 months if they failed to have a clinically significant improvement, and the majority of them did in both trials. In terms of level 2 studies, 3 of them involve the iFuse device. 1 involves the SI lock threaded screw. The Evolution study is the Symmetry device, and the Fuchs study is the Diana cage. There was a pooled analysis performed of 3 of the iFuse device studies. They had similar inclusion criteria and similar outcome metrics, which made this pooled analysis possible. With this larger cohort of patients, we were able to see that smokers and opioid users had slightly decreased improvement in VAS and ODI compared to the non-smokers and the non-opioid users, but both groups, the smokers and the opioid users, did in fact achieve an MCID for improvement. So some thoughts about outcomes data. Selection criteria are key for outcomes. Typically, 3 of 5 physical exam maneuvers being positive, as reported in the Peterson article, are required, and these include the thigh thrust, Faber, pelvic gapping, pelvic compression, and Gainslands. If a 6-test survey is used, then a sacral thrust is added. A positive response to injection is also required, but there is debate about what level of response is needed. The NAS criteria says 75%, ISAS says 50%. The best published study looking at surgical outcomes did not show much of a difference between 50 to 75 versus 75 to 100% response. So that suggests that 50% is an acceptable threshold. Also required is ruling out hip, spine, and other sources of pain, although the way that this is done has not been clearly specified. It is also unclear what effect prior spine fusion has on outcomes. We know biomechanically that a 1-level fusion increases the stress on the SI joint by about 50%, and a 2-level fusion increases it more than 150%. In a study out of Korea, Haas showed increased rates of radiographic degeneration when fusion to the sacrum was present versus floating fusion. So by CT scan at 5 years, there was about a 75% rate of degeneration with fusion to the sacrum and about a 38% rate of degeneration with fusion that was a floating fusion or not to the sacrum. And then there have been mixed evidence on clinical outcomes in cohorts of patients with and without prior spine fusions. In terms of measurement of the outcomes, the VAS or NRS is commonly used. Some studies ask 2 VAS scores, one for back pain, one for leg pain. The ODI is commonly used, and it's a well-validated tool, but it's not clear if it's truly a disease-specific SI joint outcome tool. Yet there is no better validated tool available to date. Other measures that are variably reported in these studies include return to work, opioid use, ambulatory distance, and global assessment, or compared to before surgery, how much better are you or worse are you in a percent rating. So in summary, the highest quality data available to date are the 2 RCTs comparing surgery to non-operative treatment, and these were both for the iFuse triangular titanium rod. There is prospective multi-center cohort data available for the iFuse triangular titanium rod, the Diana threaded cage, and the Symmetry screw devices. There is comparative effectiveness done via retrospective cohort studies for minimally invasive versus open, Rialto versus iFuse, and perhaps there are others that I'm not aware of. And then there are many other retrospective cohort studies available as well.